Next two talks of implementing genomics at a national level. First, we'll go down under to Australia, and Kathryn North is going to give us a talk describing implementing genomics at a national level.
Thank you. Yeah, what I thought I'd cover today is talking a bit about how we actually are going to start to get all these tools into clinical practice and how we are approaching that both at the global level, but I also will do a deep dive down under as well. I thought I'd start by reflecting on the vision of the Global Alliance and to just reiterate a couple of points here is that the vast majority of data over the next 5 years will likely be generated in healthcare. We need to have a healthcare learning system, which I'm not sure exists in many places. While we're collaborating and coordinating the various standards and policies, we also need to engage the policymakers because we need to think about equity of access and sustainability. They're all a big ask because the healthcare systems are complex. It's not just, we start thinking about the sequencing and how to store it, but in actual fact, what we need to bring along with us are the clinicians, the patients, the general public, as we've heard from Anna, ethics, going into data security, bioinformatics, liaising with the insurers, the electronic medical records, the hospital, the government. It goes on and on. This is a disruptive technology and a whole of system change is necessary. And I think in many places we're actually, as we try and get this into clinical practice, we're really laying the tracks as we go along and really evaluating what we're doing to try and continually improve it. So again, to go back to this slide that's from Ewan's early talk this morning, is how are the Global Alliance engaging with the community? And there is going to be this iterative process of the community telling us what they need, us developing the tools and then trying them out in the real world. And we've just heard a fabulous overview from Heidi in terms of the real world driver projects. One way that we're doing that, and I mentioned this briefly this morning, is related to how we roll this out at a country level. And this appeals to me because it's the most efficient way to go, is that we can start to plug into various health systems because they are not all the same, but we can start to learn from each other as we're integrating genomics into clinical practice. The national initiatives, we've had 2 meetings bringing together about 17 countries, but I think this is probably the most efficient way that we can encourage the community to implement tools and standards that have been developed by the Global Alliance. It's also inherent upon those countries where genomics is more advanced in terms of its incorporation into clinical medicine, to then be able to guide others that are just starting off. And then we can learn from each other in terms of the approaches that we've taken. So in the meetings that we've had to date, it's been really obvious that this is very valuable and we're forming a number of partnerships, particularly to avoid reinventing the wheel. Many countries are at different stages of intent or of development. The perspectives are very complementary. And we've already, over our 2 workshops, identified, apart from the overall goal to implement Global Alliance standards and tools, to actually start looking at beta testing of tools. What's the best way to collect phenotype, for example? What is the minimal clinical data set that the laboratory scientists and the bioinformaticians need to be able to interpret a genome without having to keep going back to the clinician? And they're going to vary from disorder to disorder. And how do we start to bring that data together and make it available? And who should be the rate-limiting steps in terms of the guardians of being able to order this testing? We can share resources around consent, around education, our experiences with culturally sensitive populations and our Indigenous populations. There are many, we heard from India today that there is very little genomic data available in many populations, whereas they are, quite huge numbers of people in different countries. And so we need to be sequencing and then sharing our reference populations. But also importantly, with this idea of engaging our governments, we need to be gathering the evidence in terms of clinical utility, cost effectiveness, diagnostic efficacy, how we're influencing patient management, because that is translatable across a whole different range of health systems, and it's really the most effective way to change policy. So Heidi's given you an overview of some of the driver projects, and I'm going to hone in on the area of national initiatives. And we've heard about All of Us. Sue Hill is going to talk to us about the next phase of Genomics England. And so what I thought I would do is to do a bit of a dive down into evidence that we've been generating as part of our Australian initiatives. I think the common themes about the current national driver projects is they all have government investment. It's looking at implementing genomic testing in the clinical setting. And there is method to the madness, we found retrospectively, is that there is approach of a hybrid implementation effectiveness design, which is you try something out, see how it works, and then improve it. So in Australia, we have a complex healthcare system, but who doesn't? We have a nationally funded Medicare that funds tests and funds some drugs, but we have a number of different states that actually guide our hospital system and also our genetic services. So we need to take that into account. And what we've aimed to do is to federate the states, and you'll see that over this timeline there has been the development initially of Melbourne Genomics, which I'm going to talk about in a bit more detail, but in New South Wales, later on now in Queensland, South Australia we just launched a couple of weeks ago. And what we've aimed to do is to bring together the different state-based initiatives, but also to look at how we federate and bring those together. Australian Genomics per se is only 18 months old, but the Melbourne Genomics has now been working over the last 3 years. So I'm going to start there because quite frankly, we have built a lot of Australian genomics from our learnings in Melbourne Genomics. And I'd like to credit Clara Gaff, who has done an amazing job coordinating Melbourne Genomics with some of the slides I'm going to show you. So Melbourne Genomics started off self-funded, and it was really to demonstrate to our state government that we could do genomics responsibly. In terms of developing a statewide platform, there's about 7 million people in Victoria, developing prototype systems, evaluating, seeing what works, what doesn't, but then looking at how we could have shared approaches so that a patient that had graduated from the Children's Hospital, all of their data and all of that information could transfer down the road to the adult hospital. And we did this in a model that we're also using in Australian genomics, which is prospective recruitment of patients, and also looking at specific disease areas, because this is not just the realm of the clinical geneticist anymore. We need to engage the neurologists, the cardiologists, the immunologists, the oncologists, and at the same time they're immersed in these projects, so we're training them as they go along. And really I would say over the last couple of years in Melbourne Genomics, and now that's translating nationally, we've trained up probably around 150 genomics literate clinicians as champions for the project. We started off with whole exome sequencing, and now we're moving into whole genome sequencing in many areas. But we did it, in this stage it was ethical to do this in parallel with the patient's usual investigations. So in my area of neuromuscular disease, one of our first line investigations, once you'd ruled out Duchenne muscular dystrophy, was to do a muscle biopsy and all sorts of other invasive investigations. So using this, we're able to develop shared approaches across consent, curation, a common bioinformatics pipeline that was used by the different diagnostic labs across the state, and very importantly, the multidisciplinary reviews in terms of in-house training of what we're doing. We're also rolling out currently what is a statewide approach in terms of how we're approaching the sharing of data, the collection of data in clinical practice, and then what is needed in terms of technology support from a clinical and diagnostic perspective. Now, the key findings, I thought it was good to see some results rather than plans of what we're doing. And there's now, I think, over 900 patients have gone through Melbourne Genomics. But this is great news for the Global Alliance in relation to a patient's approach and thoughts about data sharing as compared to a general public approach. When in a clinical setting a patient goes through informed consent about having a genomic test, more than 96% of patients consented for that testing. 99% of patients agreed for additional use of their re-identifiable genomic data for research. There was a very high uptake, and this was with quite detailed informed consent. And when they were evaluated at the time, and then many of these patients, or most of them have been seen a year later, the majority of patients had no concerns about sharing their data and the vast majority felt they'd received enough information and had no remaining concerns. So when you look at a patient population, they want to share their data. I think based on these data, we're actually, and using the products that have come out from the Global Alliance, this has led to a common clinical consent form, which again we're now adapting from a national perspective, but it includes the clauses about sharing of anonymised data and then an opt-in clause in terms of sharing re-identifiable data related to research. This is probably the most important slide I'm going to show you because it is one that has really influenced government policy. And this is looking at patients that presented under a year of age with a likely monogenic disorder, or the childhood syndrome's flagship. With these patients undergoing their usual investigations, we got a diagnostic hit rate in about 11%, and the cost per diagnosis of those diagnostic odysseys that we saw in the video for that family this morning were averaging about $27,000 per diagnosis. Whereas when we did whole exome sequencing in the same cohort of patients, it was 5 times the diagnostic rate, and it was at a quarter of the cost. That is dramatic. What I also found fascinating, and this is data from Zenitsa Stark, is that getting a diagnosis has a profound effect on a family, as we heard this morning. But I think this effect is much more profound, is when you looked 18 months later of the 48, this is the number of pregnancies up the top that had happened in the families where there'd been a diagnosis compared to those below where there was no diagnosis. So what we're doing here is a diagnosis is also restoring the reproductive confidence of a family, and that's incredibly powerful. So on the basis of this, our Victorian government, as well as now funding a whole of state approach to this for $25 million over the next 4 years, they've also thrown into the health system an extra $8 million in funding so that all children have access to this genomic testing based on the evidence. This will be probably one of the few policies in history based on evidence. The other thing is we're now going and liaising with our federal government in terms of getting a Medicare item number so that this would be available on a national level. So Australian Genomics is modelled on this. It's funded as a starting point as a health services research project, which is again really focusing on maximising patient benefit, demonstrating cost effectiveness, demonstrating practical strategies, but at the same time enhancing the research translation capacity within Australia. And as part of this, we have 78 partner institutions. As I said, it's about 18 months old now, but I must say I'm delighted with how it's flowing. We have a number of different programs, and I'll just touch on the National Diagnostic and Research Framework, but what we're really doing is driving activity through prospective collection of patients as they turn up in the clinic. So this is in real time going forward. We're not opening the fridge and sequencing the DNA there. And what that is driving is the collection of information, the referrals as part of a national referral network going across borders, the building up of our federated data analysis and storage and being able to model that, and then feeding into the evaluation of policy and health economics. But at the same time, we know that we have to build the capacity in this area from a genomics workforce perspective, and also look at the ethics and the regulatory issues that we need to deal with to make this more of a reality. So the National Diagnostic Network, across all the different flagships now, it differs in design. We're agnostic of technology. We tend to be moving with the times, going from panels to exomes to whole genomes, and then testing one against the other so we can tell when we need to move into whole genomes. We look at the applying genomic testing also at the right time for these patients. So it's not being done in addition to usual care, it's actually starting to use genomics early. And then capturing the health costs and the impacts on the patients. What took the longest time was actually getting now a national ethics and governance structure around the country. And we now have 30 sites that are established around the country that also act as clinical sites, but at least provide us with a network that we can keep adding onto and don't need to reinvent the wheel every time. Our flagships are across a number of different neurodevelopmental areas, immunology, renal, and we're just about to add another group in the next tranche. But actually, when we look now at what we're joining up with all these state initiatives, we have about 40 different flagships around the country. In parallel, related to translational capacity, we're mimicking the Canadian model of Forge Canada, where we're bringing together around each disease group the expertise for a functional genomics network, so that we've now got ready modelling of different disorders, but also of different pathways. This is really just not to read, but in relation to all of the different flagships, we're sort of driving activities very much mimicking the sort of work that we're doing across task teams with the Global Alliance to bring this into practice. From the Data Federation perspective, again, we're now trying to take whole of country what we have already been doing from a Melbourne genomics perspective. And I just wanted to highlight for all our geeks here that we've also made sure that we are implementing all the standards where you can see the little marks of the Global Alliance throughout our program planning. And then finally, I think the importance of policy and engagement with government. And what we have worked with our federal government and our state governments is now we've developed a national policy framework for the implementation of genomics and its principles that is going to the November meeting of the health ministers for final ratification. And that's been a national consultation, but I think we've got a great way of going forward, and it's going to have the imprimatur of government. So, going from Australia into the rest of the world, and I think the links that we have had globally have been invaluable to us and to our thinking. And we're looking forward as we share back and forth all of these different aspects. But I think Matchmaker, which Heidi has talked about, and Kim, as a principle of the Global Alliance is incredibly important. That it's displaying what Global Alliance approaches are, which are not reinventing the wheel, be practical. We need to build within the systems that we have, and embracing federation with analysis in the cloud. And I actually think as we start to pull all this together, I see Matchmaker as a first step of going towards like a Google genome. So we're going to be able to sit at our computers, type in a variant or a phenotype of interest, and it's going to pop back up with us. And it's just as I see all the different things that we're beta testing now, we want to create a Google tool advisor so that we can share experiences with the community. So thank you. I'll end there.